Okay, so now we are live. I'm with Dr. Amber Hall today, who is OBGYN. Yeah?
No, I'm no.
No, I'm wrong. I'm wrong right off the bat. Tell me what your title is, please.
So my name is Dr. Amber Hall. I'm actually a board certified pediatrician. I have two different board certifications in the United States. I now am practicing women's health. I have a longstanding interest in women's health. I thought I wanted to be an OBGYN when I was in medical school. And so I did all of my elective rotations in things like GYN oncology and pelvic floor reconstructive surgery and high risk pregnancy and delivery, like preparing myself to go into obstetrics and gynecology. But in the United States, this is a very litigious place. And every OBGYN that I talked to said, you will get sued probably multiple times in your career. And that was a big deterrent for me, obviously. So I ended up going the pediatrics route. Did a lot of additional training in newborn intensive care. So again, like taking care of people in third trimester pregnancy and like advising around prematurity and congenital anomalies and, transition from pregnancy to postpartum. And just this year, I got my Menopause Society certification. But I've been studying a lot about women's sexual health more broadly and hormones and menopause and sort of like figuring this stuff out on my own because of my own age. And now I'm doing menopause hormone therapy and women's sexual health, sort of like integrative and functional medicine here in Vancouver, BC.
Yeah, I know it's so funny. You mentioned you're American certified, but I thought it was important to point out for anybody who's local looking for women's health that you're up in Vancouver now. So, which is so fun for me because I'm a Canadian practicing in the US and Amber is an American practicing in Canada. So we've got some fun crossover there.
Yeah.
Yeah. And so the reason I invited Amber to chat with me today, live for all of you, is we wanted to talk about some really important issues that affect our overlapping specialties. So I specialize, for those who aren't familiar with me, I specialize in trauma. I am a psychologist and I work with PTSD and other outcomes of trauma and in particular sexual trauma. And so this is an area where there can be real challenges intrapersonally and psychologically in accessing really important healthcare after trauma, whether that's sexual or medical or other forms where you feel a sense of having lost control and there's a lot of fear, especially disconnection from your body. So we're going to jump into all that. So just give a real quick overview of some of the things that Dr. Amber, do you want to call you Amber or Dr. Hull or
how do you want to call me Amber? We're on a first name basis now.
Yeah,
perfect. My Substack is Under the White Coat, and so a lot of people know me as Dr. Amber through Under the White Coat.
Perfect. Yeah. So just a quick overview of some of the things we wanted to cover so you know what to stay tuned for. And also we absolutely welcome your questions. We probably, if you put them in, we'll try to find them at the end unless we're like, oh yeah, we should clarify that right now. And so we'll just see what we get to. So, but some of the things we wanted to cover today for you are how sexual trauma affects survivors psychologically and physiologically, how that impacts subsequent healthcare, and how we can gently dismantle the barriers to accessing the healthcare that we all need and deserve, through a trauma-sensitive lens, and through helping to empower you to be well prepared for those kinds of encounters. And also, what can you expect if you're going for a first-time women's healthcare appointment after experiencing some trauma? And then maybe how can you find in your area, if you're not in Vancouver, a practitioner who has this kind of lens and this kind of thing. So hopefully that's a lot, and we'll see what else we get through. So, we've talked just a little bit about our specialties. Amber does Under the White Coat on Substack, so make sure you're following her. And I'm writing mental health music Substack as well about trauma and psychology and how that impacts sometimes the things going on around us. So, maybe just
sort of start with like what I know about like gynecologic care and sort of like how I practice it and what my experience has been both in the States and here.
Sure. Yeah. I just thought maybe before we jump into it, let's give a quick overview of what trauma is. So we kind of are clarifying what the conversation is. And then I really want to hear about your specialty and how you address that.
Absolutely.
Okay, awesome. Yeah. So trauma basically is an experience that overwhelms your capacity to cope at the time that it happens. And it tends to involve a sense of a loss of control, a loss of personal power, and a lot of fear. And experiences like this often result in a spectrum of symptoms, including flashbacks, especially when there's something that's triggering or similar. And this is where we really start talking about the gynecological care. Nightmares, senses of reenacting the traumatic experience, as well as feeling like physiologically heightened and on edge. So there can be irritability or constantly hypervigilance, like you're looking for the next thing to happen, feeling jumpy, a lot. Just unable to really relax and feel safe in your body and with the people around you. And so as I'm kind of talking through some of those things, maybe you can think through how maybe that's impacted you and how that might play into how as well.
Yeah. So I can speak to this from a couple of different angles. And, I think it's important for people to know that gynecologic, like a pelvic exam, as we think of it, is optional, right? And so with any decision that we make in medicine or really anywhere in life, there are risks and there are benefits. And, that goes from Tylenol to chemotherapy to getting in a car and driving down the street. Everything has risks and benefits. And increasingly, and one of the things that is just sort of standard practice here in Canada is that we now have HPV swabs that patients can do at home. So you receive this like swab in the mail from the BC Cancer Screening Program, and you put it in the vagina, swirl it around for 20 seconds, pop it in this tube, and off to the lab it goes. So in terms of HPV testing, which is like the primary cause of cervical cancer, you don't even really have to go into an office and subject yourself to that kind of testing. The same is
that's a new testing technology, isn't it? That's just come out in the last few years.
It's relatively. I don't know how long it's been going on in Canada because I'm new here, but I went back and did a little bit more research on the US side of things too. And there now is an FDA approved self-swab available for patients at home in the States too.
Yeah. And so that's not something you've ever had before or heard of before, maybe something to ask your practitioner about, even through an email if you're not ready to go in.
Yeah. And I think they're even commercially available too, because they're, I'm learning a lot about healthcare systems and like how things are different here versus in the States. And the other thing that I think it's important to keep in mind in the States, especially is like Medicaid funding is being cut and, people aren't going to have access necessarily to primary care, that I think people need to sort of like steel themselves to the concept that they may increasingly have to pay out of pocket for some sort of like preventative things and health maintenance things. And this is one of them. And the upshot of that is that it becomes, these tests at scale become more widely available and they're, come at a reasonable cost. And also it saves you from having to like pony up a few $100s to go into a doctor's office. So HPV swabs can be done at home. Gonorrhea, chlamydia, trichomonas, those types of things can be tested for using a urine sample. So you don't necessarily need to go in for that. And, as I was preparing for this conversation today, some of the things that are reasons on the risk benefit side that may like the risks or exposure may outweigh the benefits of having a gynecologic exam are things like a trauma history. That's a perfectly good reason to decline a pelvic exam. Trans folks maybe not so interested in going into a gynecologist's office or, may have other concerns related to, the anatomy and what have you there. So I think it's important for people to know that some of this testing can be done yourself at home, is commercially available or is publicly available depending on where you live. And the circumstances surround your body and trauma history are very valid reasons to decline a pelvic exam. So what are the reasons that like really necessitate a pelvic exam? Obviously, if there's acute trauma, if there's tearing, if there's injury that needs to be repaired by a surgeon, that's reason. If you're delivering a baby, you may be subjected to multiple cervical exams, although you don't have to say yes to every single one. And other things would be like skin conditions, dermatologic conditions, lesions, things like herpes and syphilis. The gold standard of diagnosis is a swab. skin conditions like lichen sclerosis, lichen planus, genital warts, all of that stuff, like really requires somebody to look at the area and see what's going on. And my like, especially postmenopausal and older women who have not had estrogen on board for a number of years, I can actually see atrophy of labia. I can see atrophy and like narrowing of the vaginal canal. I've actually seen women who, present for menopausal or perimenopausal symptoms and like decreased libido. And when I do a physical exam, I can actually see that the skin over the head of the clitoris has fused in a condition called phimosis that interferes not only with the neurologic signal, like going from the clitoris to the brain. Obviously, if you're unable to experience pleasure for that reason, it would drive your libido down too. So there are a variety of reasons to have a pelvic exam, and there are a variety of reasons to decline. Does that make sense?
Absolutely. And I want to jump in and you can correct me if you think that I'm wrong, but say that, if you decide like it looks like the indicators are I really should go in and have a pelvic exam, know that you can also change your mind at any point. You can go and talk to your doctor and say, yeah, I'm not ready. You can say, I want this part of the exam, but not that part. And know that you have the power to withdraw consent in this as in any situation at any time.
Yeah. And I also am preparing for this. I went on the American College of Obstetrics and Gynecologists website, and there's been an increasing awareness of the need for trauma-informed care because, as you said in your most recent paper, a third to a half of women and, slightly less, but a significant number of men as well have been victims of, either sexual assault or some sort of like some women experience medical trauma, right? Related to like trying to get diagnosed with things like endometriosis or, ovarian cysts, PCOS, like just sort of
Traumatic childbirth, all kinds of
yes, yes, definitely childbirth trauma. And, I have talked to women who were subjected to like multiple pelvic exams against their consent by medical students. And, like there's a variety of reasons that people may not want to go in. So ACOG has sort of made it a policy to educate residents and, doctors in training about the importance of trauma-informed care. And also, I think, it's patients should know that there are resources available to sort of like figure out who is going to be a good fit for your needs.
Yeah.
Midwives tend to be very gentle in my experience with women, especially when with regards to a history of trauma. Menopause Society certified clinicians tend to be a little bit more sensitive to these types of things. I'm a member of the International Society for the Study of Women's Sexual Health. ISWISH has a database of providers, so you can search for, ISWISH
And what's the website for that? If you could just spell it out.
ISSWSH. I think org.
And like maybe later we can add that to the comments when we post the replay. That's a really good resource. And I would say that people can call around too when they're looking for a provider and try to, ask if there's any kind of training that the practitioner has had in trauma-sensitive care, and know that you're empowered to choose whom you're going to see and whether you're going to see the person and when.
Yeah. And I when I'm doing a pelvic exam, I ask every patient, and we have them fill out paperwork in advance. So if you're filling out new patient paperwork for a clinic to get access to hormones, for example, if it says like, is there anything else that we should know about you? You can say on there, like trauma history, please be sensitive to that. So, and I read all of that intake paperwork, right? And I ask every single patient, do you have a history of sexual assault or trauma? And some women will like burst into tears in my office, and I'm like, okay, and I explain exactly what I'm going to do for those patients who do have a history of trauma. I explain what I'm going to do while they still have their clothes on. And I have the luxury of time, right? I work in a private clinic, but as I'm going through my exam, I'm like, my hands are here. I'm going to touch here. You'll feel my fingers here. This is a Q-tip. I will show them, and I only use the smallest speculum available, and I'll show them the speculum before I insert it. But like patients always have the option of saying, I would prefer not to have a speculum exam, or, if they want to defer the exam entirely, that's okay. This is their care.
Yeah. It's more important to, you know, using an American word like to pay a copay twice
Mhm.
than it is to feel re-traumatized. And so you really have to know, like, if you're in, are you in the mental space for this? And the other thing is, that I think is important for both patients and practitioners to be aware of is one of the things that happens in trauma very, very often is that, the part of the brain that is connected to speech, which is called Broca's area, tends to shut down when we're in extreme sense of danger and trauma. And so it's very hard to verbalize it. And I want to mention that for two reasons, actually. One, and this is a little bunny trail, little side note. One is because it's so easy to blame ourselves if we're like, I froze and I didn't say anything. You know, that's your brain just trying to help you survive. So that doesn't make something you didn't want your fault. But number two, when we're experiencing something that can feel like a reenactment of trauma, which for many people, although this is obviously a trauma sensitive practitioner is trying very much to avoid it feeling like a reenactment, but it can feel that way for some people. That same process can be triggered where that Broca's area shuts off and you just find that you can't find the words. And so it could be helpful um, to communicate a nonverbal signal. Um, Maybe bring somebody with you that you feel really safe with, a friend, a loved one, a grandmother. Doesn't have to be the friend that you would go out for drinks with, somebody who you really feel safe with, and have them hold your hand and talk to them before, like, if I squeeze your hand, please tell the doctor to stop. And or tell her I'm not ready until you give her the go ahead. So you can have that ally with you that will again help you feel more empowered, more in control, and help you to communicate so that if you're in a point where you're just like, I have to just grit and bear it, but you really don't want to, you can find your nonverbal voice back.
Yeah. That's such an important point that you bring up. And occasionally, I do have patients who come in with a mother or a daughter or a partner who's there throughout the entire encounter with them. And, my adolescent patients obviously have mom with them, but I don't do pelvic exams on adolescent patients. And again, I don't work in an acute care setting where, potentially would be required to do a rape kit or anything like that. But even when I was doing pediatrics for years in the States, I generally didn't do pelvic exams on children and adolescent patients unless there was a specific concern. And yeah, I that it just really wasn't a thing. There are certain specialties. I'm not saying that it's never required.
Hmm.
There are certain specialties, especially in adolescent obstetrics and gynecology and endocrinology, where we have to do Tanner staging and things like that. But I think
What's
genital,
Tanner staging for the rest of us?
what's that?
What does Tanner staging mean for the rest of us?
Tanner staging is how we tell what stage of development a child is in terms of puberty. So, like a prepubescent child would be Tanner stage 1, and someone who had gone completely through puberty and was basically in their adult form is Tanner stage 5. And so Tanner staging is sometimes required when we're talking about putting kids on growth hormone, for example.
Mhm.
So,
Awesome. You briefly mentioned, like rape kits and that kind of crisis care. Have you ever worked in that environment?
so when I was a resident in Baltimore, I did a rotation that was child sexual assault related.
Mhm.
And there were very specific, the child wasn't examined in the emergency department. They were referred out to this specific clinic that did just that. It was it was a really heartbreaking experience for me. I didn't spend a whole lot of time there. Um, but as it relates to child sexual assault, a lot of times there's no physical evidence. And so there's a group of highly trained people, and they tend to be at tertiary children's hospitals
Mhm.
that do those types of workups.
So here in the greater Los Angeles area, we might find it at a place like Chalk or UCLA or something like that.
Yeah. And I think it's important to also mention here, and I applaud you for pointing this out in your article over the weekend, that a lot of people don't report. So
Right.
there's a lot of the stuff that goes unreported,
Mhm.
undiagnosed. And I will admit, I'm a survivor of sexual assault in my early 20s. And even when I was in medical school, we came to a part of our like physical diagnosis where we were talking about, like pelvic musculature and sort of like the muscles that hold the pelvic floor in place and the gluteal muscles and things like that. And I'm an osteopathic physician. So we had like hands-on components to that. And when it came to that portion of my education, I was like, you will touch my ischial tuberosities over my dead body. And I went to Dean about it and was like, why are we being asked to do this without any conversation about consent? And, and I kind of like got a pass on that. And I graduated from medical school in 2014. So just the evolution and the recognition that we need to be getting consent from patients. We need to be having these conversations about, trainees and medical students and residents and nursing students doing cervical exams during delivery, for example, at teaching hospitals. And, all of this stuff is just really, it's only been within the last probably like 10 or 15 years to my knowledge that it's kind of been front and center in obstetrics and gynecologic care. There was actually a movie called At Your Cervix that was done by a midwife. Have you seen this? I'm sure you probably have.
No, I just was smiling at the title.
It's a very cheeky title, but they talked about like the historical non-consensual nature of like research and clinical practice in the field of obstetrics and gynecology. It was very revealing. And fortunately, I think that there are a lot more women in medicine these days, and B, like these conversations have become much more ingrained into the culture of medicine and, like how we need to be sensitive to the needs of patients. But, all of that to say that over the course of time, at least in my experience, when I was in my early 20s, like around the time that, the assault took place for me, I was much more sensitive about everything. Like it was much easier for me to get triggered than it is now, for example. And so, I guess I have some scar tissue around those wounds these days, but maybe you can talk a little bit about that and sort of like how the picture of trauma can change over the course of a lifetime, or how it can maybe crop up in relationships and sexual experiences and professionally and those types of things. Because I'm sure that I'm not the only professional who has a history of sexual assault.
Right. Yeah. It's easy to think that the people that we look to as helpers and authorities and whatnot couldn't relate to what we went through. But, when like the statistics that I cited that you mentioned about like, up as many as a half of women have experienced unwanted sexual violence of some form. A third have maybe experienced a sexual assault, right? This is a lot of us who aren't necessarily putting a banner out there. So a lot of people do relate. And yeah, I think like I said before, safety is one of the first things that's impacted, a sense of safety in yourself, in your body, trust in relationships around you. Especially if, the most common scenario with sexual assault, with rape, is somebody that you've known. And so that also can undermine your sense of confidence in your own judgment. Although I want to reiterate, that doesn't mean if somebody preyed on you, it's not your fault. There's no, I should have known better, because people can be very, very wily, very manipulative and coercive to get what they want. And it's not your job to be a mind reader. Shame is a really common outcome, the sense of there's something wrong with me, the self-blame that kind of I'm just alluding to, that somehow it's your fault that somebody else chose to take advantage of you. And so it can take a long time to work through these negative beliefs that really hold us back. The sense of feeling constantly, like I want to say aroused, but in this conversation it sounds funny, but like physiologically on edge, right? Because your body is bracing for the next dangerous thing to happen, trying to protect you. And so there's a number of ways to try to address this. Some of it is body-based, somatic therapies, even yoga. It's a trauma-sensitive yoga, which is something that I'm also a practitioner in, so that you learn to develop safety in your body. And then as that calms, you're starting to be able to feel it emotionally and cognitively. So that's what we call like a bottom-up approach. The traditional therapy we think of as like talk therapy, like let's talk about what happened. And really I find with trauma, talking about it can be re-triggering. It can be very difficult, especially because, like I was saying, words sometimes are really not connected initially to what happened because it's so somatic. It's so fragmented um, from our logical brain, which just analyzes things. And because trauma is experienced somatically, it's experienced emotionally with all of our senses, you're not analyzing what happens at the moment of a sexual assault. So to talk about it, you're actually activating the wrong part of the brain. So like, here's my handy little brain model for anybody who's actually watching this video. In the middle, we've got like this little dot right there is the amygdala. That's your fight, flight, or freeze, right? And this kind of area around here is the limbic system, which is all the emotional, the hippocampus, which is memories in there. When we do talk therapy, we're activating this orange part, the prefrontal cortex. So you can see it's not even the same part. And so if you want to heal the trauma, you've got to activate the part of the brain where the trauma is stored, right? And so that's where we want to get into therapies like EMDR, which I'm certified and a consultant trainer in, and brain spotting, which is similar to EMDR but a little bit newer, where we're really activating that limbic system by going into the emotions, going into the bodily sensation where that trauma is stored in the body, where you feel the activation, maybe in your gut, maybe somewhere else. And the sensory fragments of it. So what I mean by sensory fragments is there might be certain visual cues or auditory cues or even olfactory, like smell cues. Like a trauma survivor I worked with had the smell of pine was associated with the trauma because it happened at Christmas time. And these little things are actually what we need to cue into because that brings us to where we need to be to heal. What we do first in therapy is not let's thrust you back into the trauma. I want to make that really clear that that's not my goal ever. Our first goal is to create safety. And so that can be about developing inner resources, outer resources like coping skills and support networks, daily practices of breath work, things like that actually help you to feel grounded, learning how to ground if you have a tendency to dissociate, because that was the way that you survived the sexual assault or assaults. If there was like a childhood history of something going on for a long time, and learning how to bring yourself back when you get that floaty feeling so that you can be present and work through what happened, but all in the context of safety, of psychological safety and physical safety as well. It's very hard to heal from something when you're not safe. Like if you're in a domestic violence situation, it's very hard to work on trauma because you're still being traumatized. And so the number one objective is safety.
Yeah. I love your philosophy on care, and I have worked with someone in the past on brain spotting, more related to sort of like the trauma that I experienced from being in American healthcare and like coming up through, all of the first and secondhand trauma of that. But I love the ideas behind EMDR and brain spotting and like internal family systems therapies and those types of things as and I understand that sometimes pharmaceuticals are required, for a period of time. Those are life-saving medications. I'm not knocking pharmaceuticals, but when it comes to like the true healing that allows people to get off of those types of medications, because, I don't really see this as being like a lifelong sentence, when it comes to certain diagnoses, which is why, I deeply appreciate your philosophy in terms of like doing the work rather than, dissociating or, developing substance use disorders or other sort of maladaptive coping strategies. I think getting to the root of true healing is such an important part of this. And that's why I love doing integrative and like functional medicine. Like all of these things are interrelated. Like I can work on pelvic anatomy and hormones and, food is medicine and those types of things. Like there's healing that needs to happen between the ears too, to get people to sort of like where they want to be longitudinally. So I love on coercion and domestic violence. So I think it's important here also to touch on the aspects of sexual violence that are maybe a little bit more subtle forms. Because I gave a talk back in the spring at the Ishwish conference talking about the difference between like sex work, like volitional sex work, and human trafficking. And a lot of victims of human trafficking don't even realize that they are being coerced and sort of like molded into a coercive situation where they're economically dependent on someone else. And then, ultimately they are being sold for sex under the auspices of being like in a loving relationship. So can you touch a little bit on the more subtle forms of sexual violence and as far as that goes, and like what is mandatory reporting versus what's not? Because this is a very gray area for clinicians.
Well, yeah. Okay. That feels like that's like two separate questions, and I think they're both very worthy to address. So maybe the simpler one I want to jump into first, and then we'll get to the second one. So the easier one, I think, in a way, even though it can be gray, is the question of reporting and what's mandatory reporting. Because I know that fear of, if I divulge this to a practitioner, whether it's a psychologist or a physician, what's going to happen? So there's a big line that happens at 18 years old. So things that happen to children tend to be reportable.
Even if there's a question, if there's a shadow of a doubt that there's
Yeah.
some sort of assault against a child, we are mandatory reporters. Physicians, teachers, psychologists, coaches, the clergy, in theory.
Ideally. Yeah. That's supposed to. Yeah, and because it's not our job to be the investigators, it's our job to report a reasonable suspicion of child abuse. Now, when you are 19 and you're saying I was abused as a child, that's different because you are no longer a minor, so you are technically assumed to be able to make the choice to get out of a bad situation, unless, of course, you have a younger sibling who is also subject to that abuse, and then that person, there could be a report because of the younger sibling. Domestic violence is similarly considered to be a problem between two adults. And so it's not a reportable offense. It's a matter of, as practitioners, trying to empower you to find the resources to get out of a very difficult, sticky situation. And now I feel like we're kind of merging into the coercion bit or conversation. It's important to know that if you have, as an adult, and by adult, I include like college students, if you have been raped as an adult, you can talk to your therapist, you can talk to your doctor, and that's not going to be reported. Crimes are not reportable unless the person is planning a crime against a specific person, and that crime has to be actually homicide. So somebody having committed a crime against you is not actually something that we're going to divulge. So you can feel, and you can feel however you want about whether or not that's right, but you can feel completely safe to tell your doctor or your therapist about those kinds of things without worrying about that next step of reporting. Because the reason I think that's really important to mention is most people don't want to report. And that's a perfectly valid choice, because I think we all know that reporting brings a whole other question. If this goes to trial, it can be very hard to move forward in the work of healing because you still have this in your face. You may feel that you're put on trial, your history, your sexual history, your decision-making, your substance use history, all of these things can be on trial. And I don't want to discourage anybody who's like, I want justice and I'm going to report this from doing so, because that's a very strong choice to do, but it's not weakness to choose to protect yourself by focusing on your healing and your mental health. It's a very difficult system to navigate through. So really, this is an area of personal decision-making and again, empowerment. This is choice. There's no right or wrong answer here.
Yeah, agreed. And I will put the caveat on the mandatory reporting for adults that adults with like cognitive disabilities and like elder abuse notwithstanding.
Yeah.
That's right.
Sorry. Oh yeah, over 65 or dependent adults. Then you can look into elder abuse and situations like that. So I guess I'm looking at that window between 18 and 65, and that's that was not really fair of me to exclude those who are 65 and over.
Yeah, this is the teamwork makes the dream work, right? And
there's always I'm glad we're having this conversation.
Yeah, there's always exceptions to every rule, and this is like, I just love talking with you and with other people who are sort of like coming at medicine and healing from an integrative mindset, right? Like so much of healthcare, definitely in the United States, but to a degree in Canada too, is siloed, right? Like you see a
Mm-hmm.
dermatologist for this thing, and you see a psychiatrist for this thing, and you see a cardiologist for this thing, and you see an immunologist or a rheumatologist for this thing. But I think so much organic disease can
Mm-hmm.
actually be rooted in a significant trauma history, including
Absolutely.
autoimmunity and malignancy and sort of like chronic inflammation and metabolic disease. The sort of like water we're swimming in can have a really
Mm-hmm.
significant impact on epigenetics and our internal chemistry. And so I think it's really important for those of us in like, and I don't know, allopathic, osteopathic, naturopathic medicine to have good relationships with our colleagues who are in the fields of like trauma healing and somatic therapy and mental health. It's just critical because it affects people's relationships, how they move in the world, their profession, their everything. So
Yeah, both impacts us on a cellular level, which means the cells throughout our bodies are impacted. And then there's endless numbers of studies that show this, that, one of the biggest ones is the ACEs study that was put up by the Kaiser Foundation. I think it was in the late 90s. And so the ACE stands for the Adverse Childhood Experiences Scale. And so with that, there's 10 areas in which they assess, that have happened during your childhood. Like, did your parents get divorced? Was it them incarcerated? Do you have physical abuse, sexual abuse? Do you have alcohol? That's some of them. There's 10 of them, obviously. And for each one of them, they found that the higher your ACE score from 0 to 10, the greater your likelihood of having a whole range of physiological outcomes. And now you might be somebody who's like, I had a great childhood, but I did have the sexual assault in high school. So that doesn't sound, or in college, doesn't sound relevant to me. But the point is that the stresses we experience impact our bodies on a cellular level. The inflammation that stress causes us is not just mental, but it's completely physical. And so it's so important to let yourself focus in and heal the traumas that you've experienced, whether they started when you were 2 years old or 22 years old or 62 years old. And know that healing is possible, and it's not some negative prophecy for your life that, well, if I have all these bad things happen to me, I'm going to get cancer. Like, healing is possible. It's a big warning sign that you need to pay attention.
yeah. Yeah, I agree. And there's a lot of conversation right now about like the diagnostic and statistical manual and sort of like these codes. And the reality of the situation is that those diagnostic codes exist because of payment structures.
It's all insurance. Mm-hmm.
and and MSP uses it in Canada too. Like I put a diagnosis code on my billing statements, even if I'm, billing public insurance for certain things. But I think it's important to keep in mind that there's a lot of neuroplasticity, and you know more about this than I do, sort of like in your field, that just because you have a diagnosis doesn't necessarily mean that it's for life and that trauma healing can happen. Tonight, I'm going to a workshop here in Vancouver that's presented for physicians by physicians on the topic of psychedelic assisted psychotherapy. And
that's an exciting topic.
yeah, they're going to talk about ketamine, they're going to talk about psilocybin, they're going to talk about MDMA and sort of like the legal frameworks around these things and sort of how they're utilized as tools to, get to root causes and trauma history and like true healing that hopefully allows people to get off of long-term pharmaceuticals. So
there's so much promising research coming out around that in the last several years. So that's probably a whole nother conversation for another day, but something that people can look into as well.
Yeah. Absolutely.
I skirted around your earlier question about coercion, so I wanted to make sure I didn't drop that question entirely. I think you asked about people who aren't even aware that they're being coerced, that they might be being trafficked. A lot of times it starts early on when you're a minor. And the interesting thing about the definition of sex trafficking is that when you're a minor, so the definition of sex trafficking is that it involves force, fraud, or coercion. And like you said, coercion is kind of a nebulous thing to define. But when you're a minor, those aren't necessary to prove, because the fact that you're a minor means that you're a dependent person. And so therefore, if you're having to trade sex for survival, for lodging, for something like that, it's implied. And so a lot of times, most times people, enter into the sex trade at a very young age before they're an adult for survival reasons because they've been thrown away, they've run away because they have an abusive background that they need to escape. And they get wrapped into this boyfriend relationship and the person comes in as a hero. They're like, I'm going to take care of you. And then it's like, well, I need you to do this for me. And it's seen as an asset that you have to provide. But what I always think back onto is, nobody put that down on their kindergarten paper for what they want to be when they grow up. This is a choice that's made from limited options. So it's important to kind of trace the roots back to where did this begin for me? Is this truly what I always wanted for my life? Or do I feel like I have limited options? And that's kind of where coercion gets into that gray area.
Yeah. Yeah. And you're absolutely right that it tends to, in younger people, and I know this from my research for the talk that I gave in April, but it tends to be that trafficking victims, like child trafficking victims, it's often a family member who is the perpetrator. Queer kids and trans folk are much more likely to be victims of trafficking because of sort of like rejection by the biological family and sort of like violence at home or getting thrown out of the house, that type of thing.
Yeah, kids who are on the street are usually approached, like half of them are approached within the first 24 hours by somebody who wants to traffic them. It's really dangerous.
Yeah, it's really common. But I also think it's important to note that, economic status, like, I don't know, I hear stories of, things that I would perceive as being sex, like sort of low grade, gray area sex trafficking and, women my age and where I'm like, are you sure that this is voluntary? Like it seems like it has the illusion of being consensual, but I think that there's some coercion going over here and it just sort of gives me the ick. So,
And some other ways that people control somebody is by controlling access to a child that they may have fathered or just taken control of, sometimes holding a personal identity document. But a lot of times it's a lot more entangled and psychological than. On this topic, I wanted to throw out a hotline number that's really helpful. Like, if you don't have to know even like, well, do I fall in these lines or not? But if you're starting to question, feeling like I do want to change in my life, you can call this hotline just to chat and just to chat about your situation and see if you want to explore any resources they might have to offer. And so that the National Sex Trafficking Hotline number is 888-373-7888. It's like a nice little parallel number. So 888-373-7888.
Yes. Yeah. And I know that here in BC, there are organizations that support sex workers and victims of trafficking and domestic violence. So there are resources out there and available, and you can find access to clinicians who are sensitive about these types of things, mental health care, sometimes financial resources and help to get out, like economically, to get out of situation that you decide you don't want to be in anymore. So,
and again, if you don't know where to start, another option is just talking to your clinician, your physician when you go in for an appointment, and see if they have some resources they can connect you with.
Yeah, very good. Well, should we wrap this up?
Yeah. So, I don't know if we had any questions pop up. I don't think I saw any. Did you?
I didn't. I've seen. Thank you guys for coming in at 11 o'clock on Wednesday. This is amazing. What a great turnout. But I didn't really see any questions. I saw a lot of people joining, which is amazing. So, yeah.
Okay. Well, maybe we'll just wait one more minute. If anybody wants to quick type something in, we're happy to answer it. I think we covered what we mostly wanted to. Ways to find a practitioner with this kind of trauma sensitive lens. You mentioned that one website, Ishwish.
ISWISH has a database of registered clinicians, and ISWISH, the International Society for the Study of Women's Sexual Health, is a really it's a collective. So there are mental health professionals in there, there are researchers and academics, there are physicians, nurse practitioners, just people like pelvic floor physical therapists, people whose clinical expertise is sort of surrounding the women's sexual health. And we tend to be an inclusive group. We can tend to be a very open mind and queer friendly group as well. There is the Kink and Polyamory Aware Professionals Network, and people can, and that's not just physicians, also, it's other professionals too that sort of like register as being, cognizant of these things. And what else? ACOG, the Menopause Society has a searchable database of registered Menopause Society certified practitioners who also tend to be a little bit more sensitive about these things. And ACOG in general has just sort of taken a stance on the importance of trauma informed care. So I appreciate my colleagues over in the academic side of things and teaching our young trainees coming up how to be sensitive about these issues for folks.
Yeah. And let me just mention a few places because I had talked about EMDR and brain spotting. If you're looking for a practitioner in your area who might have those certifications for trauma healing on the therapy side, you can go to EMDRIA, so EMDRIA.org, and there you have a Find a Therapist tab. So you can search there in your area, in both Canada and the United States and around the world. And for brain spotting, you can go to brainspotting.com, and they also have a Find a Clinician or Find a Therapist tab there. We can also, there's some people trained or certified in that. Two of the best trauma approaches for healing trauma. Somatic, IFS, also great approaches. Something else I just thought of as we were chatting just now, in the United States, with a lot of states having really harsh regulation around abortion, if that would be something that would stop somebody from getting a pelvic exam who otherwise might, what are some options there? I know on the therapist side, we have a registry that I'm part of. That's abortion supportive clinicians for care and non-judgmental care. Is there something like that for physicians where somebody can find somebody in the United States where they might feel a bit safer?
So this is a really good question, and I'm not going to pretend to know the answer. I'll give you a couple of brainstorming things that come to mind. Planned Parenthood is still I don't know what the funding situation is for them. I know that they've had a lot of their funding cut off and kind of become a target. But Planned Parenthood tends to be a good resource for the jurisdictions where it's still present. I would just caution folks on crisis pregnancy centers tend to be fronts for anti-abortion organizations who try to maintain pregnancies for people who are seeking to terminate them.
They don't have doctors on site.
Yeah. I think also it's important. And one of the things kind of tying it back to Substack, that I'm going to be doing coming up, I'm putting together a young women's program, both for my clinical patient and also I'm planning to run it on Substack, talking about period tracking and ways of preventing pregnancy for people who don't want to be on hormonal birth control, either because they're at clot risk, or they just don't want to be on those high doses of hormones, or maybe they just don't have access to hormonal birth control. And so I'm going to be doing a series of educational pieces on, just this is your hormones, this is your cycle, this is what it looks like. If you don't want to get pregnant, these are ways to try to avoid it. I actually wrote an article several months ago called How to Get Down Without Getting Knocked Up that has some resources in that article. It talks about what it was like getting an IUD placed for the first time, but within the context of that article, I point to some a website that lists physicians who will do a bilateral salpingectomy on women who have not given birth yet, because you might be surprised that some doctors are no, I'm not going to tie your tubes or sterilize you because you don't have children. And which is taking a lot of autonomy away from the patient. But there is, and I think that there will increasingly be these sort of grassroots and whisper networks of people who are providing services and like connecting people with needed services in the United States and elsewhere.
Awesome. Thank you.
Yeah.
Well, thank you so much for your time and for everybody who gave up like almost an hour to be with us today. And
Yeah.
I know everything that Amber has shared has been so valuable.
Yeah.
Thank you so much. If you are new to Amber, please go check out Under the White Coat on Substack, Dr. Amber Hull. If you search by either of those, it should pop up.
Mm-hmm.
And if you're new to me, I'd love to have you join me over at Mental Health Musings. I'm under Dr. Deborah Vanal. You can find both of us there. Thanks for joining us.
Very good. Yeah, you're welcome. It was my pleasure. I hope you have a good rest of your day. And thank you, everybody, for showing up on a Wednesday. All right. Very good. Bye.